So today we'll talk about some alternative strategies for cost control. And we're going to start out looking at how effectively single payer reform, and we'll look at it in theory, and you're going to be looking at it in reality next week as we look at different countries' healthcare systems. So with the observation that that hospitals spend a tremendous amount of money on overhead costs. And in a single payer system, basically all the money that is spent on insurance within insurance companies would be immediately eliminated if you had a single payer system. You would be left with only one bureaucracy. And if it were to be regionalized or delegated to the states, that needs to be implemented thoughtfully so that you're not inflicting unnecessary administrative costs in the regions. And I want to be frank with you. I'm speaking to you as future leaders in the system. I'm assuming we've already had what you're going to see when you're looking at countries with single payer systems is there was, I won't use the word revolutionary, but there was significant progressive change. In Taiwan's case, shortly after overthrowing a dictator, you're going to see that same pattern. In Britain, after electing a progressive government when they adopted national health insurance in 1911, and then after the catastrophe of World War II, countries decimated. They weren't screwing around with for-profit insurance companies. They just wanted to get health care to their people. They had no insurance system. The insurance system was kind of weak, and there was no infrastructure. So what I'm saying is, you already, by the time, even after 2 weeks of this internship, you're already, probably in a position to think effectively about these strategies. And so I'm speaking to you as people who I hope will be in important policy positions when the country finally changes. You guys are young, and there's a lot of years left in your lives, hopefully, and a lot can change in the country. So this is what we've talked about already, that as the number of doctors increased from 1970 to 2017 from 350,000 to around 900,000 active physicians, the number of managers just grew exponentially. And so we've got all these people in insurance companies, and it's funny when you hear the rhetoric from the people that elected Trump, the idea people that elected Trump, that there was this swamp of useless bureaucrats. But in reality, there is no system, there is no healthcare system in the world that has resulted in the proliferation of administrative work more than the United States. And second place, it isn't even close. It would probably be Switzerland, if I had to bet. This one I'm not sure of. Let me go back to this. So in general, with cost control, this is the same thinking as in public health. Do not rely on one strategy to control costs, because there's going to be efforts from special interest groups coming from every angle to fight it, and they might win some battles, and you'll lose some cost control when they do win those battles in general. I'll talk about how that would happen later. But so don't rely on one strategy. Use every single strategy you can. So when I hear people in the Democratic Party say, no, you don't need to work on liability reform, it's only 1 or 2% of spending, I'm saying no. We're taking every single percent we can. And if the trial lawyers lobby wants to divert healthcare money to court costs and to their salaries, that's their battle. But I'm fighting it because I'm wanting healthcare money to remain in the healthcare system, treating my patients. So that's my primary principle. Do not divert money unless you absolutely have to. And evaluate every strategy, be ready to modify it, evaluate right from the start. When you implement a strategy, you implement its evaluation at the very time you're implementing the strategy. Okay, I really like this idea. The planning group really likes some idea, but the planning group needs to also evaluate it right at the time. How are we going to see if this actually works? We all think we're so brilliant. We want to do this. We have a consensus. Okay, fine, but evaluate it. See if it could change. Ask people on the front lines, what do you think of our little strategy? And be ready to change. And absolutely be ready to fight entrenched interests. And always try to get ideas from the trenches. The ivory tower is less useful. And you've got a lot of models in other countries that are of interest and have been tried, and so you can see what other people have tried and see how it went. And as I said before, fight for every single percent cost control you can get, and don't give up any of those fights, because there will be people who will want you to do that. Okay, so I'm going to talk about single payer reform first, because I don't know of a more effective uh, strategy to control healthcare costs. Now, when you heard Dr. Weisbart talk about single payer reform, you left that thinking, it looks good for costs, but also the idea was that it was getting everyone covered. And in the PNHP version, there's no copays or deductibles. So at the point of care, when you're at the doctor's office, there's no financial deterrent for patients getting the care they're seeking. So, anyway, so that will get everybody care. Everyone's included. So from the point of view of people who feel social solidarity, when you know that there is a family in a poor community who has a sick child, you may not know that person, but your heart is saying that you want them to be able to see a doctor if that kid really needs help. And you don't want deterrence. Those are your values. A sense of social solidarity is probably why you're in this internship. So, so single payer reform looks really good from that perspective, that everyone is in, and they're getting comprehensive coverage. So that looks really good from the point of view of being humane, basic decency. But now let's go back to it and now look at it, just the first two, universality and comprehensiveness. Let's look at it just from the point of view of cost control. So let's say you have a healthcare system that includes 80% of the population and doesn't include the other 20%. So and I want you to look at this question from this perspective of the billing office in a medical practice. Put yourself in those shoes. You're a billing person in a doctor's office or even in a hospital. And you're getting, and the doctors that in your practice who are working there, they saw patients and they're sending down to you or they're emailing to you bills that they had a middle level outpatient follow-up visit, or they had a new patient visit, which is complex, or they did a procedure, they sutured up a boo-boo or something, and and they sent you a procedure code to bill for those. And the question is, how easy or complex is your task? So if you're in a system that is universal as opposed to one with 20% excluded, in the universal system, everybody's in the same insurance system. What do you think the task is like for a billing person in a doctor's office? So the doctor's sending you down codes from different types of visits. And you think it'd be easy to learn your job and get to be pretty quick? No guesses on that.
Yeah, I think especially since you don't even need to remember where you need to send the code to, there's only one person. And I'm assuming, like you said, all the states use the same code. It seems like someone could get pretty good at it.
Right, and maybe you could even imagine that you didn't even need the billing clerk because you could just email the bill directly to the billing system. You know, if you're in a Canadian province or something like that, they're all going there. Why even have an employee? So you can greatly reduce the number of administrative jobs because the task has become so simple. And let me just make one comment on that. All of this type of proposal of single payer reform, simplified systems, they involve very significant job loss. You can't, Bernie Sanders is always saying, "Oh, everybody will get health care. We'll have more healthcare jobs." Well, yeah, we probably will, but I think there's going to be more job loss, and the people who are losing jobs aren't trained to be nurses or other high types of healthcare workers. So I I don't want to sort of sugarcoat this. There would be significant job loss, and this is accounted for if you read the PNHP proposal. So you're saving money. A lot of it is personnel costs. Anyway, so let's go over to the system where 20% of the people are not even covered. So what kinds of actions might those 20% do with absolutely no coverage that is going to affect the billing clerk? What might happen in the private sector of, people in companies that are offering fire insurance and homeowners insurance? When 20% of the patients, a lot of people are not covered, what do you expect might happen?
Those employees might lose their jobs.
Which ones? Which employees?
The ones that were, I forgot the word you just used, but the ones that are administering the healthcare to these 20% of people who are no longer insured.
You mean the 20% of people in the doctor's billing office?
Oh, yeah. Sorry. I think I
Yeah.
misunderstood that. Yeah.
Okay. So they'd have a little less to do.
Yeah.
Okay. I'm going to argue they're going to have more to do. Can you imagine why that might be? Anyone can answer this. Because the 20% of people who are excluded, they're still going to get sick, right? And what's going to happen when they get sick?
They end up in the emergency department.
Right. Or they could go to that doctor. And what's going to happen when the doctor generates a bill for those people? It's not going to the single payer system because it's not a single payer system. You excluded 20% of your population. So the doctor generated a bill. What are you going to do with it? As a billing worker.
I I know currently if someone doesn't have health insurance, sometimes hospitals will sell the medical debt like debt collectors at like
Mhm.
a steep discount. So maybe if we're assuming we ban the sale of duplicate coverage, like in the current PNHP proposal, they'll have a lot more administrative difficulties with collecting payments from uninsured population.
Yeah, I made a mistake in the question I was asking. This is no longer a single payer system. You've excluded 20% of the people. So it's not a single payer system. There's just 20% of the people with no coverage at all who are still going to get sick and still might want to get a mammogram and, whatever other healthcare they need. So if you're a billing clerk and a patient comes in who doesn't have health insurance, before you give up on collecting their debt and send it to, sell off your debt, wouldn't the billing clerk send a bill to the patient? And it might get paid, you know, you never know. But the patients, this 20% of the population who are excluded, if some insurance company is in the city that they're in or in the country, in the country they're in, it seems like the insurance company could say, well, there's 20% of the people, several million people who don't have health coverage. I'll sell a policy to sell them healthcare coverage. And, maybe I'll have a deductible and a copay, but it'll cover them if they get sick. And if enough people enroll, then I'll make money. So then the billing clerk is now facing other insurance companies, and 80% of the bills go to the central government, but the other 20%, they might send it directly to the patient's insurance company, and then they have to bill the patient for deductibles and copays. So by excluding 20% of the population, you're adding to the billing clerk's workload, because some of those bills may not get paid right away. The insurance company may hassle you. They may deny care. They may do all kinds of things. But anyway, each bill is going to have to get sent in two directions, and you're going to have to exert some administrative expense to get that collected so your practice has enough revenue. Does that all make sense? Does that seem reasonable? And then I think you can get to Zach's step where some of it you won't be able to collect, and you could try to sell it off to debt collectors or get collection agencies. It's all administrative work, spending, it's all costs money, and that's healthcare money. So the question is that what we want to do with our healthcare money? Or do we just want it to go for healthcare? So what I'm getting at is that by having everyone in the system and not exclude large portions of the population, you're essentially reducing administrative costs compared to having a system with many, many people excluded. And the same thing can be said for comprehensive coverage. So in other words, I have Medicare. There's 20% co-insurance in Part B, and 60% of Medicare spending is in Part B, which is lab tests, doctor visits, specialist visits, lots, x-rays, cancer infusions, all kinds of stuff is Part B, all outpatient care, outpatient surgery, a lot of that is in Part B. So 20% co-insurance, it's not okay. I'm liable to, go bankrupt with that. So I buy coverage, and in fact, it is for me. I said what would happen to 20% of the population we're not in, but the question about comprehensive coverage, what if 20% of the cost we're not in? Then you're either going to have to bill the people who got insurance. You're going to start billing their insurance companies, which is what happens when I seek care, or the people who can't afford to buy insurance, who are hoping for the best. You're going to bill them, and some of them can pay and some can't. So by Medicare's benefit being so weak with 20% co-insurance, they're creating a system where people are going to want more coverage and have a lot of co-payments, and you're building an administrative expense. And you may be saving Medicare some money, but you're not saving total healthcare system spending. You're just diverting some of it to insurance companies and people who pay premiums for insurance companies and patients who have to pay their copays and deductibles. So total system costs, it doesn't help, but the cost Medicare itself has to bear does drop. But it's creating, with its weak benefit, it's creating a system where the system as a whole costs more. You're just diverting costs onto people. So what the result of all that is that for the Medicare population, their out-of-pocket spending actually averages $5,000 a year. If you include their purchases of health insurance, if they're in Medicare Advantage, they're going to have copays and and for every single visit they have. The dentistry's not covered. So all kinds of, prescription drugs are partially covered. So there's a lot of out-of-pocket spending, and so you end up with $5,000 on the average. And then, including premiums to get Part B. And so anyway, so you have, so universality and comprehensiveness are not just humane, they're cost control strategies. You're controlling total system costs. The rest of those on this list are not nearly as important in terms of cost control. But however, portability, meaning if I move from one part of Vermont to another, or if I change jobs, the fact that there is nothing happening, nobody lost insurance, nobody gained insurance, nothing happened. So that saves administrative effort too. So universality, comprehensiveness, and portability, they all save money. And I also feel that accountability, having employees have some input and people have input, could go either way. It could create a system that works better and is more efficient, or it could just say there's more demand for more services. We'll end up having to build more services and could increase system costs. But certainly universality, comprehensiveness, and portability will reduce administrative costs. So I'm going to stop there to look for questions. Does that make sense? Okay, I'm going to not leave it yet because we got one more thing to do with single payer reform, which is that when it's universal, there's another advantage. Now, what Yuva Reinhardt noted was that 90% of the difference in cost between the US and other countries was in prices rather than volume of care, the number of visits. And prices are the big difference. So yesterday I said that all these administrative costs, if your billing clerk has more work to do and you have to hire another one, then you got 2 salaries to pay. And those salaries are then built into your fee that you're going to have to charge in your practice. You have to recoup the administrative costs. So that leads to higher prices for doctor visits and hospital visits because you have a much bigger billing department to fund. And that's going to be reflected in your fees. So that's adding to prices being high. But there's something else, which is when everyone is in a system, you end up with the country has the biggest possible system they could if everyone's in it. So in the US, 341 million people are in your system. So when you look at the drug companies setting prices really high, if you care about your budget and you see that the US is spending double what the other countries are spending on pharmaceutical costs, you might say, okay, I don't want this anymore. This is not working out for us. And we're negotiating on behalf of 341 million people, and we really don't want to spend any more money than what's reasonable. So we're going to work on this, and we're going to negotiate with drug companies as one important part of that effort. And when we get to this section of this internship and pharmaceutical costs, you'll see that, yeah, the negotiation of getting prices down via negotiation or even potentially price setting, where the single payer is so powerful that just says this is how much we're willing to pay for, Wegovy or whatever the drug is. And you can either produce it or not produce it. You're willing to take on some fights. You have to be willing to fight if you're trying to create a cost-efficient system. So the universality allows you to negotiate prices for everything down. EKG machines, hospital beds. So it's it gives you a powerful tool in reducing all input prices. So now we've had 2 huge benefits from single payer reform. And I have to say, that's why so many people who actually want to have a humane system are looking to single payer reform to provide that system and give everyone the care they need. So now I'm going to leave it. And giving places a budget. So a budget for the system as a whole, single payer reform would lead to a drastic reduction in administrative costs. Do you guys know what reinsurance is? So some self-insured companies who only have 750 employees, they have to, go to Barclays of London and pay for a policy in case they have a bad year. And that's pure administrative costs. Wouldn't even exist in a single payer system. And another issue, when you have the entire population encompassed in your database, then you can say, okay, so there's a urologist in Lockport, New York, that appears to do 95 cystoscopies in a day, every day. And if that urologist had been sending bills to 10 different insurers, there would be no way to know that. But with a single database, you can pick out fraud much more effectively. So it allows you to detect variation in care, some of which may represent fraud. And then the other thing you can do is try to say, okay, what's the population need for MRI scanners? And now that's determined by the profit motive, like which facility that wants to open an MRI, machine or whatever, whether they think they can make money based on the investment and personnel costs. But with an organized system that's looking at population need, you could try to put obstetrical units where they're needed rather than where they're profitable only. So you can, a favorable match between population need and technological dispersion, is a useful strategy in creating an efficient system. And then you could try to also improve public health, which can also save money if you make sure everybody gets, relevant vaccines. So single payer reform, which I didn't even write down here, that's sort of pretty key. And now I'm going to go to other strategies. You're going to learn more. And from Dr. Verhoff last Wednesday, you heard about privatization, the for-profit hospitals, and the fact that they do cost a little more. And we talked about the fact that they spend money on investor relations and, have high CEO salaries. And anyway, so you heard about the effects of having infrastructure owned privately and especially publicly traded on Wall Street. Later this week, you're going to hear about private equity ownership, which is probably even worse in terms of cost control. Also, the privatization of Medicare and its fragmentation has been extremely expensive. Same for Medicaid. And then medical advertising. Why is elective orthopedics advertised, but not an annual visit with a primary care doctor? It's, the payment system is a mess, so people are advertising to get more of what's profitable under the current dysfunctional payment system. And then you spend more money on advertising, diverting healthcare money out of the healthcare system into marketers. And then, lobbying has many detrimental effects and, buying politicians. 2 out of 3 people disapprove of the job Congress is doing. Who's the third person? And, obviously the lobbyist is pretty happy, and so are the special interests that the lobbyists represent. Okay, so another question is how to pay doctors and hospitals. So how to pay hospitals is going to be the topic of the next talk, so I'm not going to say a word on it. But paying doctors, we can have a session about how to pay doctors. I don't think there's a perfect answer. One thing I can say is that paying primary care doctors so much less than specialists is not having beneficial effects. Because you've already heard that having a strong primary care system reduces system costs, in addition to improving quality of care, improving public health. So that would be certainly one thing to do in how to pay doctors, is make sure primary care was properly funded. And this is not mentioned by PNHP, but this I think is, so I'd say there's 4 strategies that are the most effective at cost control. Single payer reform with universality, portability, comprehensiveness, that's sort of, I'll count that as 2, that they can negotiate down prices and reduce administrative costs. I would say the hospital part of this, which you'll hear about later, is probably up there in the top 4. And I'd put this one on the list too. If you're designing a new healthcare system, you got to go to this one because this is going to really pay off. And the good thing about dealing with the mess of electronic health records in the United States is that you'll have a chance to make the doctors and nurses and other healthcare workers so happy. You will have a whole lot of satisfaction. There are obstacles, but during the first decade of this century, there was a realization that electronic records would be helpful, that theoretically all the doctors in hospitals could communicate with each other, and somehow it would be more efficient than having to sit there writing notes and getting notes dictated and all of that, transcribed, getting them into the thing, and there's all this paper. Then the patient shows up in the ER and the paper record is nowhere to be seen, obviously. So you didn't even know what meds the person's on, much less what diseases the doctor's treating. So this was going to solve all those problems. Okay, so that makes sense. That's all true. So what did they do? Instead of saying, we're going to have a record and we're going to work on it together and everybody's going to be on that system, what did they do? They said, okay, you want Medicare payment. You have 4 years to institute an electronic health record. And in the first 2 years, if you get it done quickly, we'll pay you a little extra. And in the last 2 or 3 years, if you haven't gotten it done by then, we're going to penalize you financially. But we're not going to give you an electronic health records. Good luck. I hope you can find one. And at that signal, this is, I think it's called the High Tech Act. This is supported with bipartisan, supporting the US Congress. Always be fearful when there's bipartisan support for a bill on healthcare. Anyway, so that came out of Congress. And so some people and little companies were working on developing healthcare software. And suddenly when this bill passed, they said, oh, great, we're going to have customers. Instead of slowly developing a really good system that doctors might want to use, now we're going to be forced to do something pretty quick. So they took whatever they had gotten done and they really moved ahead with it. And they worked on it really fast and they created crappy systems that everyone hates. And they wanted to get it on the market because almost as expensive as adopting an electronic health record and training all your employees on how to use it and, getting all of that to work, they have security systems and passwords and, where to chart your notes and where the labs are going to come in and where the X-ray reports are going to come in and how to make sure you've seen all the new results and dealt with, when you deal with them, it has to go somewhere else. How do you send a patient a note? How do you send other healthcare workers? It's a really complicated thing. Okay, so fine. So they rushed them to market, but not just one company, all these companies that have been working on it. And here's what you ended up with. And this girl is looking at this and it's like, oh, great. I don't understand anybody else's record. And there were hundreds. And so we have Babel. And in the 11th chapter of Genesis is the story of Babel, where people were being arrogant and they wanted to look up and build a tower to the sky so they could see God. And God said, I didn't want you to do that. I told you not to do it. So he gave them all these different languages and they didn't understand each other. And this is what the High Tech Act did. So now we've all got incompatible software. And the effort to try to bring everyone together has been expensive and relatively ineffective. And what has resulted is what often results in a competitive market is that there started to be market consolidation. So now you have a few of the programs are sort of solving the problem by winning this battle. And they're not better. I use Epic, which is the biggest one, and I was shocked at how horrible it was because I had already used 4 or 5 others and they had issues. I had one that was my favorite, least non-favorite, and Epic's problematic to say the least. But it's sort of winning out. So all the hospitals that have Epic, it's a little easier to get the results. So we've sort of created this monopoly, and Epic is really expensive. And the ones that won out in the competition are expensive. So in that op-ed piece that I wrote, which I encourage you to read, the VA actually has had a system that's way older. It's decades old, even from the 1970s, believe it or not. They were working on it early 80s, already implemented by the late 1980s. And so it's old and it needs to be updated. And they were gonna update it in approximately 2008 or 9, create a new system that was good. And the neoliberal forces in Congress said, no, we're not gonna pay for you to develop software. You're gonna contract it out. And they contracted out to Cerner, one of the other software vendors, I'm gonna say the second or third largest one, and it crashed the first day and has never recovered. So privatization does not always mean better quality. And so the VA is still stuck with their old record and, slowly being modified. But it's an incredibly inefficient mess that everybody hates. And what should happen, the federal government should take the time to work with all the, as many geeks as they need and as many types of healthcare workers so that they have a chart that's pleasant to use and that communicates with everybody. And they should give it to all the doctors and hospitals in the country free of charge. And even to help train people, to make sure the software is working and, all the things you train computer people for. This is in the top 3 or 4. And unlike some of the other strategies, this one improves quality of care drastically over the mess we have now. And it saves money. And a lot of strategies that save money to improve quality, it's hard to improve quality and save money at the same time. So this is high on the list. So dealing with the software mess is a really important thing to do. And it can also, you have the potential, if you really work hard to create the right system and take the time you need, if it takes 4 years, then it should be piloted and give people a chance to use it and do it right and make it good, and you would have a gem that would really help your healthcare system and create a lot of satisfaction. So again, link the software to every practice, give it to everyone for free. We're going to talk more about the pharmaceutical sector and strategies to save money. So I'm not going to go over it right here. Some other strategies, I don't know how much savings we'd have in total system costs, but again, raised the question before, is it helpful in some way for medical students to have to pay so much to go to medical school? And many other countries charge nothing for medical school. Some of you may be more familiar with India. I think that they don't have high fees, but they require a service to work in a shortage area. In many states in the United States, you can get a shortage area scholarship. I got one in that funded my medical school, a lot of my medical school expenses. So, the medical student makes a commitment to work in a poor community or rural area after they're done with their training. And in return for that, they get money to help them pay for medical school. So that kind of thing could be done. Furthermore, you could bolster primary care by creating training that trained you in primary care. Because, back when I was trained, I left primary care. I mean, I left medical school literally more comfortable treating a cardiac arrest than a boo-boo on a 3-year-old's arm. I swear this is true. And you could tailor the training so that you make primary care a priority and incentivize work in rural areas. So anyway, you guys must have thoughts on that. Any thoughts on how you think the most functional way to fund medical education? All right, if none, I will go on. So here's another one. There is now, so the software vendors, by the way, have a lobby now. So you're now going to fight a special interest to do what I just said. Staffing is kind of the same thing. So it turns out that rural hospitals in particular, if a doctor leaves there or retires, for them to be able to hire another doctor is very expensive and on average. And if you try to put an ad in the New England Journal or the Annals of Internal Medicine or surgery, whatever, it's really expensive. And you don't know how many people are going to see that issue, whether it's online or in the paper version of it. Either way, both cost money. So it turns out to be very costly, and it's very hard for a little rural hospital to start making phone calls to training programs, to a residency program in family practice if they're looking for a family practice doctor. So private sector firms have gotten into the business. And so Springfield Hospital, only 80 miles from where I actually was living, was looking for a medical director for their hospitalist program. And I kind of actually wanted to live, to live in that part of Vermont anyway. And I didn't know because they didn't have the money to advertise. So what happened is they hired a staffing firm, the hospital did. And one of those people called me on the phone and said, they're looking for a medical director down at Springfield Hospital. You have training in administration and you're an experienced hospitalist. So, does this position interest you? And it did. I ended up taking the job, and $40,000 got paid to the staffing firm from a hospital which was on the throes of bankruptcy and eventually actually did go bankrupt. $40,000. So that's not trivial. And as long as I stayed in the job for 2 years, they got the money. There was a contingency in the contract if I left. Some of it would have been refunded. Anyway, so that's how the contracts go. If I'd been a surgeon, it would have been 90,000 or 100,000, based on, and those costs are based on expected revenue from that surgeon would generate for the hospital. So this is being done in an extremely expensive way. It doesn't have to be. You could, here's what it costs. So I have a personal relative who does this staffing. She works for one of these staffing firms, and she's sort of in a mid-level administrative position. And she told me that they have 25% return on revenue. So it's a lot of money being diverted out of the healthcare system to profit for those who own it. So what you could do, you could have this federal government actually create a website and say, here, every hospital that had a vacancy or every doctor's practice that was having a doctor retire, they could post their position. Is this a permanent position or is this just vacation coverage? You could divide the country up by state or by, rural or urban. You could, a good software developer could say, search for jobs that are in New York City that are in an anesthesia. Or, only search for an anesthesia job if they're paying more than $350,000 a year. So you can do that. We could have one database, costs very little to run, and you would basically be socializing this sector. So there would be no more money going to staffing firms. So you're now fighting another special interest. But this is not a trivial cost. It's probably fifth or sixth on the list here. But you guys, you're kind of getting the idea. This just is something I noticed. Other people might not have noticed it. But when you're in working in a hospital, you probably notice something else that could be done a lot more efficiently if there were a system that gave a damn about efficiency. And so, anyway, so in general, reduce diversion of funds to outside efforts. And even regulation is duplicative in the United States. Who expects hospitals to see if they're safe? Well, it's more than one organization, and that could be consolidated. So every single thing when you're involved in planning a system, just every single thing, could you spend less money? You have to care. And I think that's the bottom line. And so, that's, I think, how people who are going to be leading a new healthcare system have to think that in a single payer system, if that's what you're going for, every single thing you spend extra money on that you could have saved money on means a tax increase. So you got to avoid them the best you can. So any thoughts about all that or questions? All right, so let's take
I
a
have one quick
break.
question.
Yeah, go right ahead.
So back to the medical education topic. I think I
Yes.
saw this comment online or somewhere that the actual percentage that medical schools use for their costs is like really low. I was wondering if you like have seen anything like has there ever been like a study like looking into like how medical schools actually use the money from tuition?
I don't know. I'm really sorry. I'm not into that literature.
Hmm.
I
Yeah,
have this I have this belief that if somebody worked on it, they could probably save money and make more people happy. Maybe reduce tuition.
yeah, because I think I
Just
saw something online that the actual percentage used is like very low, but I didn't like see like anything to back that up. So I wasn't sure.
I will say a lot of it is complicated and indirect. For example, most of the clinical faculty are paid nothing to teach. It's sort of an expectation of their job, but they'll lose their job if they're not bringing in research money. They're not going to lose their job if the students rate them as a bad teacher. So that's not going to be in the top list of factors that determine, whether you're going to keep your faculty position. So you might want to design a system where there was actually an emphasis and some sort of reward for, if the students rated this teacher as being really effective. And I think a lot of what the payment for medical school is very indirect. Like Medicare pays a higher fee for a hospital stay if you're in a teaching hospital. And the Medicare figures that some of that money will be diverted for education. And so a lot of it's really indirect. It's sort of we haphazardly fund our education system. But I'm sorry, I'm disappointing you, but I
Oh,
can't answer
no
the
worries.
question. Any other comments?
Sorry, along that same vein, our school, one of the things I want to write a testimony about, our school's increasing tuition by 21%. They just let us know a couple weeks ago. And they told us that it actually costs about 100,000 to 120,000 to fund a medical student through every year through their medical education. I haven't seen any papers that back that up. That's kind of what they told us when we were kind of pushing back on them. I don't know if that helps answer your question either, but I truly don't know where those funds are going because at least for our school and I know a lot of other medical students might resonate with this. I mostly use third-party resources anyways. So I don't really understand where this money is going. But I was wondering, say we stay in the same privately insured world, to decrease cost of medical education, could we impose like a tax on private insurance companies or like pharmaceutical companies? Obviously they won't go for it, but like, is that something, that's an idea that I had.
Why not? I mean, all of these ideas with fighting special interests.
Yeah.
So yeah, pharmaceutical companies have huge amounts of money. And, those of you from in the wrong group already saw how much money they have, that they just give it to everybody they can to buy favor. And so, yeah, you can do that. I will say that the cost control ideas I was just presented today I'm trying to reduce total system costs, the need to spend money. What you're doing with that strategy is you're just tapping a different source. You haven't said anything that can reduce spending. I'm not sure we should reduce spending on medical education. I don't feel I have enough expertise to even say that. I know we spend too much money on drugs. The prices are too high. I know we spend way too much money on administration, but I don't know how much the right amount of money to spend in medical education. Maybe it should be better and we should put more money into it. Maybe for primary care education. I don't feel I know that. So you're just tapping other sources, which are sources that are really tempting to tap. So, yeah.
I just found the post that I was like thinking like that I saw earlier, and there was like the most recent AAMC report showed that the sum of like your tuition and your classmates' tuition only contributes to about 3% of the operating costs of medical school. So I'm like, I don't really fully understand like where the rest of the money goes, but I can like share that in the chat.
You mean where the rest of the money's coming from? If
Yeah.
you're only contributing 3%. Yeah, good question. You can find that out. If you poke around the internet, you probably can find it out. Obviously you have to check reliability of your sources.
Can I ask a
Okay.
follow-up question to this
Yeah,
topic?
go right ahead.
Sorry if I'm cutting into our break time, but I was thinking like after like Therese and Anna's comments like how NYU funds all of their medical schools, and I thought that after like that happened, like other schools were considering doing that. So like I don't know if NYU is just like the richest school, but like how are they able to fund their medical students, or like, and like do you think it's realistic for like other schools to start doing this?
They're the one that started having no tuition or something like that.
Yeah, they
Yeah.
offer, I think, free tuition.
Without even a promise the student will work in a shortage area. Is that right? Okay.
I'll Google it. That's what I thought, but
Uh-huh.
I thought that was about like they got a huge stipend or donation or something.
Oh, right. Okay.
Sorry, Jay, I cut you off.
No,
Yeah.
I was gonna say the same thing. I think Einstein in the city is the same, and this isn't a peer-reviewed claim by any means, but I'm just looking it up online. I've seen there's some podcasts and articles about how these schools who have gotten these tuition funds from billionaires that give all their students free tuition for a number of years, they're not necessarily observing a change in the specialties these students are applying to and end up selecting at the end of their school. So there's this, I mean, not to contest what I also agree. I think if we change the way education was, the debt that we're all stacked with in general, I think our selection of specialties would change, but that's not exactly what people are seeing at these select, tiny samples, essentially. Like students are still choosing the same specialties they were, it looks like.
Yeah. All right, well, let's break till 10 after 10. And then we'll spend some time on the discussion for the high deductible stuff. and maybe start Adam Gaffney's tape, and maybe we'll take a little break in the middle of that too. So we'll meet at 10:10. We were supposed to, yeah. So today we'll talk about extend our discussion of medical savings account high deductible plans a little further with just some discussion. So, but I do want to add a point. Did anyone who has like a background in statistics, nobody reacted when I said you put money into your medical savings account during the good years when you're healthy, and then the year you're sick, the money's there and you can use it, tax deductible. Any of you statistical people have a little problem with that notion? That's the rhetoric that comes from the advocates of that type of scheme. The sample size there is 30, say 30 years if you start such a policy when you're, say, 28. And then you live 30 years, at which point you're 58. There might have been some bad years. Anybody have a problem with that from a statistical standpoint? I'll give you a clue if you want one, but if you want, anybody want to venture a guess? Yeah, I'll give you a clue. What if you develop multiple sclerosis when you're 29? And you're taking this drug, the drug alone costs $91,000 a year. And then you have a bad year, you end up hospitalized a couple times. And there's a better year and you don't hit the $5,000 deductible until April instead of, you usually meet it in January or February. So at the end, after 30 years, you've now lived with multiple sclerosis for 29 years. You've paid out $5,000 every single year, except for the first one, and you have nothing in your medical savings account. So in all the years after that, you're paying $5,000 deductible, which your earnings may be low because you got multiple sclerosis. You may not be eligible for every single job or, training programs. So what I'm getting at with the statistical question, 30 years of lived life is not an adequate sample size to say that this idea that everybody's going to be able to accumulate money. What about the healthy people who live 30 years and they barely spend any of their, if they actually were $5,000 going into that every single year, they might have a fortune. If they were healthy, they could probably earn more. And it's tax deductible. So if they're in a high income bracket, having tax deductibility, gets you a lot of money. The interest grew. So at age 58, you've made a fortune, really. And the other person never even really got to use the policy. They just had a high deductible plan. So the impact this has on people with chronic illness is dire, really. It's not going to help them. So you can argue the policy really helps people who are healthy. And the question I have is, you're designing a health system that's really good for healthy people. Well, is that the goal? So I think that's something to think about. And I just one more comment. So that was the ideal model. There would be a medical savings account. Your employer might put money into it, and then there would be this attached to a high deductible plan. But what's really happening is a whole lot of people are paying a whole lot of deductibles, almost every policy now. And some people have medical savings account with less of a deductible, A lot of them do have a deductible because it's hard to get a policy without one. So I'm just saying that was the theory. I gave you all the theory that the advocates said, but pretty breaks down pretty badly when you start getting into the details, and we're looking at it kind of statistically. So anyway, the question I had for you guys, would it increase out-of-pocket costs compared to a high quality plan with just some low copays, or Canada where they don't pay any out-of-pocket? So you're all agreed on a yes, right? Yeah, it does, for sure. And it's all out-of-pocket costs, heavily funding the entire system. And then the next question was, does it increase administrative costs? By the way, I didn't mean to give you hard questions. These are easy for the most part. Okay, so let me ask you a different way. Does it reduce administrative costs? So I argued that a single payer system with minimal or no copays is reducing administrative costs greatly, because in the doctor's back office, there's only one insurer, so they got an easy task. In this system, have you done anything to reduce administrative costs? No. And even the first $5,000, you know what actually happens when you go to the doctor and pay, and obviously you're paying the bill for the first January visit, you do get a statement from the insurance company that says, you've now spent $142 towards your annual $5,000 deductible. So we're paying nothing. You're paying 140. You paid 142. That's it. So there's still an exchange of letters. They're still keeping track. You might be keeping track for a lot of reasons. And so the administrative flurry, and there's presumably all the people who advocate for this, they tend to be in the political right. So they want multiple insurance companies competing. So the back office of the doctor, lots of insurance plans, lots of billing going on, right? A lot of billing going on because not everybody has money out of pocket. If the visit costs $247, not everybody can pay that right off. So a lot of administrative activity. So I agree with you on that one. Okay, now we have the question of whether if you had multiple insurance companies competing and one of them provided really high quality coverage with maximum $5 copay on anything and no deductible, and competing with a company with this kind of scheme where there's $5,000 deductible, with or without a medical savings account, what would that competition look like year after year? And I'm gonna give you a clue if you want one.
I think
You
I
can
have an
answer it without the clue. Go ahead.
based off of what you've told us about Medicare Advantage and how people are so attracted to these like low upfront, like consistent out of pocket costs compared to what like Medigap and Part D would be, it seems like people are more inclined to just take the risk and buy the worst care with a high deductible. But maybe that's just old people. I'm not fixed
So,
anything.
Zach, what would you do if going into Medicare at age 65, you didn't have a whole lot of money, you had some money, but not a whole lot, and you're really healthy? You'd do what you just said, most likely, right? If you didn't have a whole lot of money, you'd take the less expensive plan. But what if you were really kind of sick and you got a whole lot of health problems and you were thrilled that you reached 65 because now you're going to get some help from the government? What would you buy then?
Yeah, I would buy the traditional Medicare plan with Medigap and Part D.
You were thinking, yeah, if you're thinking your cost could be $10,000, $20,000 in any given year, there's
Yeah.
a 50-50 chance because you already got a lot of illnesses. I mean, let's say you have diabetes and you had a small heart attack 2 years earlier. Now you're entering Medicare. If
Yeah.
you looked at the statistics, I think you would rationally do what Zach said. Does anybody disagree with Zach on that? So now all the sick people are going into the one plan, and the healthy people are likely to be lured into other plan. So each year, the insurance company has to say, what did we pay out? And what was our revenue? And so if all the healthy people go into the high deductible plan, then the next year they actually might, and all the sick people went away from them, the sick people who generate 70 to 80% of healthcare costs, and they kind of stayed away from the high deductible plan. And then the next year, each of those insurers has to decide how much their premiums need to be. What might happen? One of them might be able to lower their premium. The other one might have to do the opposite, right? I mean, think about that. All the sick people are going into the Cush plan. But they're not getting any healthy people. And they have to establish their insurance rates the subsequent year. What might happen? Based on the prior year's experience with how much they had to pay out.
Might increase their rates.
Which one would have to increase their rates?
The insurance company with enrolling a lot of sick people.
Exactly. So their policy the next year, now if they're going to keep their coverage exactly as it had been, now they're going to have to charge more to get the policy. So they become more expensive. They might already have cost a little more because, you know, in the other company, people have this deductibles, so the company immediately saves $5,000 because they don't have to pay the first $5,000. So each enrollee, they're saved $5,000 from day one. So they already had a lower premium. And now Jay's saying if all the sick people took the good policy, then more and more of the sick people are going to be attracted to it. And so the high deductible plan, which already had that advantage, can now lower their rates even further because they're not getting sick people that they have to spend a lot of money on. So each year that goes by, the policy that's really good is getting more and more sick people and getting more expensive. So now they're only getting the really sick people, and the crappy policy got all the healthy people, and it can remain quite inexpensive and maybe even charge even less. So this is called an insurance death cycle. That's the term in the business. They call this a death cycle. When you're an insurance company and you're getting all the high risk people, you're going to die. Your policy, your company's had it. So, and this isn't just theory. This actually is what happened in the individual market. The people who worked at gas stations and, didn't get health coverage, who wanted to get insurance for their families, and before Obamacare, especially, or mostly, I should say, those policies were unbelievably expensive, like $50,000, $60,000 a year. I couldn't believe it. I actually saw a person who had a quote. It's $13,400 per quarter to get an individual insurance policy. Anyway, so yeah, what you lead to is a death spiral or downward spiral. And what really does happen in reality is that the company with the good coverage starts getting rid of the good coverage and starts putting in deductibles and doing things to not end up with all the sick people who are going to, lead to a death spiral. This is not a weak argument. This is a good argument for a single payer system. You know, you have competing insurance companies. The best thing they can compete on is to not take care of the sick people. And I would argue that if you're creating a healthcare system, why don't you just say, we're going to take care of everybody, try to keep everybody healthy, and, you know, do the best we can. And we will take care of you when you're sick. And we'll, you know, hope you stay healthy, and we'll all benefit with lower taxes, more people stay healthy. So to me, that's a real argument. Zach, go ahead.
Do you think that like traditional Medicare is currently in like an insurance debt spiral with Medicare Advantage, and like eventually it's just going to be so unprofitable to have traditional Medicare since it's just sick people and all the healthy people want a Medicare Advantage, and then it'll just like dissolve? Is that like a process that you think is happening currently, or is that too much of a stretch?
Um, I have to tell you, over the last 3 years, my rates have gone up about 30 or 40%. And these have been bad years in terms of health utilization. So I don't question that. If the overpayments to Medicare Advantage are significant enough, and those of us so that people keep enrolling in it at high rates, and the sick people are going to be left with buying these supplemental plans, I think it's entirely possible. The argument against it is that actually people really like having insurance. That's good. So a lot of people just will keep paying, and a lot of them are healthy. Like I'm a good bet for them. I mean, I had a bad year orthopedics wise, but you know, other stuff didn't happen. I don't have anything that is going to lead to costs later on. So I'm pretty good. And I don't want anything to do with it. And you know, private insurance does have a bad rep in the United States. So you know, there are favorable forces, psychology of it, you know, that you like to have good coverage, you feel more secure. So that psychological advantage may outweigh this, but yeah, I think it may be happening to some extent, because I have had a 30 or so 40% increase just in a couple of years. Yeah, go ahead, Inanna.
I was wondering, so we have the like high quality plan that's enrolling sicker people, and it started off with a lower premium and then it's increasing as more sicker people are enrolling. And then we have the HSA high deductible plan that more healthier people are enrolling into. But then wouldn't they, as the premiums go up for the high quality plan, wouldn't more people start funneling into the HSA, and
Yeah,
then over like it would just kind of fluctuate over time like
no, it leads
or
to
go down for the high quality plan that originally had lower premiums? As sicker people start funneling into the other one, would they ever decrease their premiums again and then
the high deductible plan may have the opportunity to keep decreasing their premiums
um,
and having even more of an advantage because they're getting all the healthy people. And then they start getting slightly sicker people, but by that time the other plan is so expensive that it's, you know, probably not even getting anybody to enroll. So that's the ultimate thing. Okay. So when the high quality plans, let's say there were only two health plans and, you know, the ones we've been talking about. Okay. So if it gets more and more expensive on the other side, on the high quality side. And so more and more people say, well, that's ridiculous. I'm pretty sick, but I'm not that sick. So now they're getting more and more sick people. And ultimately, they totally went out, and then they got everybody, which they didn't really want, but that's what they got by winning too well. So, you know, you could argue that they just kind of want to mostly win, but not entirely, not too much, or they're still getting sick people. Absolutely. That's a good point. Okay, so will high deductible plans, medical savings account, discourage preventive and primary care? If you don't mind, I want to pull up the graph. I should have put it up earlier. Um, maybe a little hard to find. All right. You know, I warned you that I would show this graph over and over again. I swear to God, I'll find it. It's not that. Oh, I didn't find it. It's this. Yeah. Oh, no, no, that's not it. The one with the sick people. I thought I had it. Nah. All right, the one that showed that sick people take most of the cost. What I wanted to show you, I would have found it, is that graph had a lot of people really spending almost nothing. I don't know if you remember the graph, but in almost all those graphs, where 10% of the population spend the least, 10% who spend the second least, and it goes over. And you see the 70 or 80% in the high spending two groups on the right. But if you really look at the, say, the 5 groups on the left, their spending is incredibly low. Just really, really low in most of these graphs, especially for someone your age. A lot of people your age don't even have a single medical encounter, or, maybe one, in a year. Maybe, who knows, a pap smear or something. I don't know. Who knows? Anyway, so you go, so there's almost no spending. And if you take an entire community of people who are, say, 19 years old, very healthy age, and they're all mostly healthy, and you put them in a $5,000 deductible plan, how many times are they going to have contact with a provider? This is the time of life when people have the least disposable income. They tend to be poor. Unless they're, living off they may be living off their parents, but again, their parents may not have a lot of money. So just talk about higher risk people. They started smoking when they were 13, maybe try a few drugs, and they're, whatever. So they're engaging in risk behaviors. A lot of people do in their teen years. And you're giving them a $5,000 high deductible. There's a whole lot of recommendations about the care of people, between 13 and 25 or 26. We're supposed to counsel them about substance abuse, alcohol, bicycle helmets, all kinds of things that we're supposed to talk about to young people. In addition to pap smears and some, other medical procedures, vaccines, contraception. If they're interested in having a child, maybe they should see a doctor and take a vitamin with folic acid. There's just a lot of reasons you want to see young people in your practice. The last thing you want to do is have a healthcare system where young people who are going to cost your system almost nothing, you're discouraging them from their first and second visit with your health plan when you want them to see the doctor. And I have to tell you, some health plans are now offering a free visit once a year, a physical or some sort of visit. It's not enough. Yes, you should give them a free visit, but if they actually think something is wrong, they could be right, and they're young. And if you're missing something when they're young, it could affect them for a whole lot of years to come. Or if they're worried about something, maybe it's because, I don't know, they had their first sexual encounter and they developed a rash somewhere. And you could talk to them about safe sex and contraception and HIV and the whole deal. It's an opportunity. You don't want to discourage those 50% from getting health care. You want them in the healthcare system. This is what your primary preventive system is there for. To keep people who are healthy, to keep them that way. This is the last thing you want to do if you're organizing a healthcare system. So this is another one of the effects of high deductible plans. Is how do you get healthy people who you really want to have come in? How do you get them to do that? So on the contrary side, I asked you if the system is likely to control healthcare costs. And if you're going to say no, so I agree with you, but please explain why.
There's no regulation. Like everything's market driven. If one place hikes up the cost, another place is also going to hike up the cost to compete. And then it just spirals.
I'm not sure I got that.
I'll let others talk.
Okay. You're saying if there's a bunch of for-profit insurance companies, you have to pay for their overhead and their profit and all that? Is it more administrative costs? So you've done nothing to reduce administrative costs, so that's going to add to total system cost.
Yeah, but there's also, since there's no regulation in price of procedures or cost of devices or anything like that, then it's controlled by the market and so costs would probably end up going up if people have these high deductible plans and have to pay more for them. I don't know if I'm thinking about this right. And I'm
Well,
so
let
sorry.
me push you further. Okay, so you're 19 years old, you suddenly have a neurologic symptom, and you go to the doctor, and you have a second cousin who has multiple sclerosis. So you go to the doctor, and turns out you do have multiple sclerosis. So they did all these tests, you paid for all of it, and now you're up to like $2,742. That's what you've spent to get an MRI and, and neurology visits is contemplated, or you say it's done, and you have this prescription that's going to cost $92,000 a year. And I think what you're saying is that nobody's reducing prices. And Yuval Reinhardt said that prices are the problem in the United States. So is that individual person, or even its drug company, if there's multiple, I'm sorry, even the insurance company, if there's multiple insurance companies in the United States, are either of those in a position to lower that $92,000?
No.
Well, the
I think
19-year-old is going to call the CEO of the drug company and say, I think $92,000 is highway robbery. You should charge me less. I'm kind of poor. And what's the CEO going to say?
that sucks.
No, it's going to say, why did my secretary get me divert this call to me? There's an underling here that should have gotten this call. Don't you think so?
Yes, absolutely.
Okay, so you're not going to get too far as the individual, but what the track record in the United States is that all the insurance companies, they don't have much of a track record either to reduce anything, including hospital beds and other stuff too. So you're basically back in the track record of the US healthcare system. You're really not controlling the costs of people who are sick. And that's where most of the cost is. You're discouraging the really healthy people who weren't going to cost much anyway. That's who's getting discouraged. So it hasn't worked. But for the insurance companies, it has worked. It's just the total system cost never went down. So that, yes, they've made a little more profit by the high deductibles. They work for the insurance companies. They can outcompete competitors, which we already talked about. And people are paying more and more out of pocket with these plans. Okay, the next question is, do they divert healthcare costs out of healthcare? Here,
Yeah.
I'm talking more about the medical savings account.
Yes, because then the money would go to the banks.
Yes, exactly. So who lobbied when this proposal first happened? And people were lobbying for tax deductibility of medical savings account. Who do you think lobbied for it? The banks. Exactly. Exactly. And so that's for sure, you're diverting money. It wasn't a small amount, it was large enough for them to lobby for. And then the other group that's winning big here are rich, healthy people. Because now they're getting all this tax deductible money that they're earning interest on over, for all the years. So you're taking healthcare money, diverting it to healthy, wealthy people and to banks. And again, I'm a hawk, healthcare money, you should go for healthcare. So anyway, so I don't have a whole lot more on that. Any final thoughts that people have? This this is what's going on in the US.
Oh, so there is an increase in these type of plans right now, like high deductible. Is that what?
Yeah, overall deductibles are going up. This fantasy of having everybody with a medical savings account attached to high deductible kind of didn't happen that way. It was basically rich people, the people who did develop, get these health savings accounts, they tended to be wealthier and healthier. So it did that right from the start. But I think the percentage of the US population who has them may be less than 20. Could probably look that up and figure it out. And then on the high deductible side, it wasn't suddenly everybody had 5,000. It was more like they creeped up and there was more and more deductibles. People with more and more policies had ever higher deductibles with the effects we've already talked about. So it's just deterioration, in the whole system just kind of gradually becoming less accessible, harder for people to pay for out of their personal money. It's what's going on.
Is this a
Part of what optimism I have is because the system is working a little more poorly each year. And these crises that are slow to develop, sometimes it has to give at a certain point. Therese, go ahead.
Sorry, is this a solution embraced by both right wing and left wing, or is it currently only right wings that are like advocating for this?
The medical savings account with high deductible. Yeah, it was the fantasy of right-wing economists and taken up by the right wing. If I ever succeed at finding a conservative to talk to you, it's the most likely thing that they may advocate for. By the way, it's not easy to do to find free market people who are getting paid a lot of money in these highfalutin conservative think tanks to get them to talk to medical students. It's been a daunting task. I've yet to succeed this year, but I'm working on it. Yeah, any other questions on that?
Yeah, I don't, you mentioned wealthy people, and I just thought about what's his name? Mark Cuban, and didn't he do like some online drug pharmaceutical company where drugs are a lot less and he outsources them or something? I just wanted to know your thoughts on that. Do you know what I'm talking about?
There's a scramble for anything you can get, and if he can get people lower drug prices, it's cool. I don't know if what he's doing could be institutionalized.
Mm.
I just don't know that. Does he aspire to every single American would work with him? Is that what he's working on? I don't really know.
I don't know. I just know, obviously I know him from Shark Tank shows, and then I saw he was doing this and I thought it was cool, but I always wonder if there's ulterior motives.
Yeah, I don't know. I'm sorry. I haven't looked into it. And I know there's a show called Shark Tank, but I've never seen it. So can't really comment. I'm really sorry I'm out of touch with the culture.